Welcome, everyone, to the G6PD Deficiency Foundation's first webinar, weighing the benefits and risks of the COVID-19 vaccine for the G6PD deficiency population. Hello, I'm Keely Harris, the president and founder of the G6PD Deficiency Foundation, whose goals are to bring forth awareness, education, and screening to those who are G6PD deficient, and to the medical health providers who have G6PD deficient patients. We have a very busy itinerary tonight, and we'd like to remind the audience that all can submit a question during the discussion by going down on your screen to where you see Q&A. Just click on it and submit your questions there. We have a lot of viewers tonight. There are well over 200 registrants, and we'll try to select questions that were not answered during the talk. We have two amazing doctors who have volunteered their time and efforts to help many make an educated decision of whether to take COVID-19 vaccine. The foundation has received so many inquiries in regards if the vaccine is safe for the G6PD deficient population. Hopefully tonight's webinar will answer these questions you may have. We have a wonderful key speaker. His name is Dr. Daniel Griffin, and he's here to discuss mainly about the COVID-19 vaccines. Dr. Griffin is a chief of infectious diseases at Pro Healthcare. He's a clinical instructor of medicine at the university, at Columbia University. He is the president of the Parasites Without Borders, and he's often a speaker on a science podcast that has become very popular since COVID-19, and this is called This Week of Virology. So welcome, Dr. Griffin. We're so happy you're here.
Oh, well, thank you for having me, and thank you for everyone taking time out of their busy days and to attend this. And hopefully this will be educational, informative, and you'll get a lot of your questions answered by the end of this evening.
That's wonderful. And I wanted to also introduce the guest speaker, Dr. Dan Vick. And he's going to orchestrate the questions to Dr. Griffin, as well as at the end for the audience questions. He'll be asking those questions as well at the open forum. Since 2019, Dr. Dan Vick is a member of the graduate teaching faculty in the Master of Health Administration program at the Central Michigan University. He also serves as accreditation and capstone coordinator for the program. Dr. Vick is a physician by profession. He specializes in pathology. After several years in military and private practice, he transitions to executive leadership roles with the hospitals in upstate New York, as well as Indiana. And since the outbreak of COVID-19 pandemic, he has published articles relating to COVID-19 and G6PD deficiency, and is continuing his research efforts in this regard. Welcome, Dr. Vick. It's so glad to see you here tonight.
Thank you, Keely, for having me, and good evening to you and Dr. Griffin, and hello to all of our attendees.
So I think it's time, let's begin this exciting topic. Thank you.
Okay, with no further ado, shall we post our slides? Let's get our slides up there and we will go. Just to give people a sense of the evening, I'm going to spend about 15-20 minutes giving a little bit of background, a little bit of context, and then plenty of time on the questions and answers. So we're going to be talking about COVID-19, we're going to be talking about G6PD, and we're going to be talking about vaccines. All right, let's go to the next slide. Let me go through how we're going to do this. We're going to start by just really, I think for everyone here, why are we here? What is this G6PD deficiency? And then what I'm going to do, once we sort of have a sense, and I actually want to point out, this is going to be important to understand the disease and the geographical distribution. We're going to discuss a little bit about the disease, COVID-19, the phases, the stages. And then we're going to move into the vaccine types. And then really the fourth part is going to be what happens if you get a vaccine, what happens if you get COVID-19. I'm really going to be comparing the oxidative stress of vaccination versus disease. So everyone take a deep breath because here we go. Next slide, please. So G6PD deficiency is not one thing. And a lot of people in the audience hopefully realize this, but I'm going to reinforce this. So one is this is a rather significant issue. G6PD deficiency is the most common enzyme disorder of red blood cells in the world, with approximately 1/2 billion people affected. Right? This is not an orphan disease. This is actually an underappreciated disease. G6PD is X-linked. And one of the things that we're going to see when we look at maps here in a moment is the distribution of G6PD deficiency matches regions with historically elevated malaria prevalence. And then on a final note, we're going to talk about the fact that there are various degrees of G6PD deficiency. So we'll talk about, special circumstances where shared decision making needs to come in rather than broad recommendations. So next slide. So one of the things I want to point out about G6PD is there are regional prevalences in different parts of the world. And if you can see here, sub-Saharan Africa is one of the areas where we see incredibly high incidence. Southeast Asia is another area. And I want to draw everyone's eye to, I'm going to say West Africa, West Sub-Saharan Africa, because this is the site where we actually used one of the vaccine technologies that I'll talk about later. Just think of Ebola. But G6PD is something that is, I'll say, common and underappreciated in the United States, in South America, in Western Europe, in China, really all throughout the world. Next slide. So what about disease severity? Not everyone is the same. Not every person with a G6PD issue is the same. There are over 200 variants, and we actually break down severity into 5 classes, right? So we have the most severe, the class 1, less than 10% activity. And most of these individuals are having a chronic hemolytic state, a chronic hemolytic anemia. Then we move into another, still this very low level activity, a class 2. These people are periodically having hemolytic anemia. And then class 3, and this is really a large group, the group that we'll be, in many ways talking about tonight. This is a group where stress-induced hemolytic anemia is seen. The range of G6PD activity can be down to about 10% of normal. It can be up to 60% of normal, and there's a gradation in here. So even within this class, we're going to see varying levels of severity given different stressors. And then we have class 4 and class 5, which actually is increased activity. It's not really a deficiency, but falls into G6PD spectrum. All right, let's go to our next slide. So now, what about when G6PD and COVID meet? One of the big things about COVID is timing matters. Timing matters so much in life, but it took many people months to really get this with COVID. There are 3 periods and 5 phases. So there's the pre-exposure period. That's hopefully where we're talking about vaccines. A person has not been exposed. And then we move into the second. We're going to see this graphically, an incubation period where potentially you've been exposed and the virus is incubating. This gives a window before we actually have detectable viral replication. And then we're going to move through our 5 phases of disease. Viral symptom phase, an early inflammatory phase, a secondary infection phase, the multi-system inflammatory phase, which we've probably heard about in children, but also in adults, and then this tail phase, which really took a lot of time for the medical community to acknowledge, embrace, cease to be dismissive regarding. Okay, next slide. So let's look at this graphically, sort of laying it out for people. We are hoping most people in the audience are still in the pre-exposure period. That's why we're talking about vaccines tonight. We're hoping we're still in that period when masks and mitigation and all these other things can protect you and vaccines can get in here. But this sort of brings you through these various phases. The early time when the virus is replicating, it actually will often reach a peak before anyone even has symptoms. By the time the person ends up in the hospital, that second week, that's when the immune system ramps up. That's when we see the rise in our antibodies. That's when we see the cytokine storm. That's when we see the major early stages of the oxidative stress and all the other immune stresses on the body. So let's just talk briefly about pre-exposure. Next slide. And briefly about pre-exposure brings us right into vaccines. What is the most effective thing we can do in this early period? I think we've been impressed at how effective the active vaccine types are. We talked about cleaning. There was an incredible amount of hygiene theater, more bleach probably used in the last year than in all of combined history before then. We talked about masks and social and physical distancing. We were really shocked and surprised how effective these active vaccine types are. So let's go through the active vaccine types so everyone feels like they have a background, a comfort, and then this will be a large part of our Q&A. So what are the four major types of vaccines? The whole virus vaccines. People are hopefully familiar with these. These are in many ways what people say is the most traditional. This is the polio, the different types of polio, the Sabin and the Salk. Then we have our viral vector vaccines. We're going to talk a little bit about those. That's actually how we ended the last big Ebola outbreak in West Africa. So another technology that we have years of experience and really large experience with. Protein-based vaccines, the new and improved shingles shots, a few of the others. We'll talk about this. And then, the newest player on the scene, the nucleic acid vaccines, the Moderna, the Pfizer. So let's go through each one of these in detail. But let's start by understanding what is the point? What are we doing with these vaccines? And there's going to be a little bit of immunology, just a little. So next slide. The whole point of these vaccines is to teach our immune system about SARS-CoV-2, the virus that causes COVID-19, so that should an individual be exposed, the immune system is ready to go, it recognizes it, and it knows how to respond. And the biggest target here is going to be the spike glycoprotein on the surface. So let's go. How do we do that? What is this education all about? Next slide. It really comes down to two really critical types of cells, your T cells and your B cells. Your T cells need to learn so they can make antibodies, these soluble proteins that circulate around that target that spike protein, which have the ability to neutralize the virus before it can even get into cells. And our T cells, which come up usually even quicker, 3 or 4 days, they ramp up. And they are able to recognize a cell that is infected that has the SARS-CoV-2 virus in it and actually clear those viral factories from the system. But how do we do this? How do we show that protein to our B cells? And how do we show it to our T cells? Well, let's go through the technology. Next slide. This is the traditional. We've been familiar with this for, well, many, many decades. I don't know if any of our listeners are old enough to remember Sabin Sundays. You would go to the local gymnasium, you get a little cup. There was a pink sugar cube in there, and that had the oral polio Sabin. This is where you basically take the virus, you weaken it a little bit, and you give a chance for the person to see a weakened virus. Body educates, but the virus is attenuated, weakened so that it cannot cause serious disease. Or I should say, the chance of causing serious disease is greatly diminished. But remember, these are active replication competent virus. This is something you have to be careful in giving to someone who doesn't have an intact immune system. The other, also going back to polio, was the Salk polio vaccine. You grow up a whole bunch of vaccine, and then you use formaldehyde, you use light, you use some chemical that actually takes that virus and makes it unable to replicate. Um, in the world of COVID, we actually have Sinopharm out of China, really good data showing that when you take this, it gives you this robust protection. A nice thing, again, as you'll see here, and you'll see going forward, this is not an active virus. This cannot make you sick. It cannot give you COVID. All it does is give your immune system a chance to learn. So moving from whole virus vaccines to, next slide, the viral vector vaccines. And we have a bunch of these. As I mentioned, this was the technology that we used over several years to end the last Ebola outbreak in West Africa. This is something that has been administered prior to COVID to almost 200,000 individuals, children as young as 4 months of age, pregnant mothers, nursing mothers, women who want to be pregnant and nursing mothers down the road. This is a vaccine where we fortunately have years of safety data. And shall I point out that area in West Africa where the platform was used, about a 20% incidence of significant G6PD deficiency. So this is actually a platform, a type of vaccine that has been used in a high prevalence G6PD population with a several year track record of safety. So this is the platform that J&J uses, Sputnik V, the AstraZeneca. So we have several potential COVID vaccine options here. Next slide. What about the nucleic acid vaccines? Not DNA in this case. We've been using a lot of those in animals for a while, but RNA vaccines. That's the Moderna and the Pfizer. This requires you to do a little bit of work. This is the IKEA vaccine. We give your body the sticky note with the instructions. Your body has to take that RNA and make it into protein, make it into the spike protein. And then your immune system, your B cells, your T cells can see that spike protein, and the B cells can maturate into effector, into memory, and produce those antibodies, those protective T cells. One of the little curious things here is we see a strong reactogenicity. They're describing a lot of people feeling like, hey, I felt like for a day or two I was under the weather. And we'll talk a little bit about the millions of people with G6PD that have successfully used this technology and done quite well. Next slide. Protein-based vaccines. So none of these are out there yet for COVID, but Novavax is undergoing review in the UK, and it's going to undergo review here in the US when it finishes its phase 3 trial. This is really pretty simple. Just don't mess around with viruses. Don't mess around with attenuation. Don't mess around with RNA. Let's just make a whole bunch of that protein. We're going to stick it together in what looks like a little daisy wheel here. Give it to people so their immune system can see and learn from the experience and move forward. And so far, this is a tried and true, very traditional vaccine technology. We're using it for HPV vaccines, hepatitis B vaccine. We use it for the Shingrix. And the Novavax is the one that we are looking at using for COVID-19. All right, it's going to bring us near to a close. Next slide. There's a couple last things we're going to say. So comparing the vaccines, the whole virus vaccines, traditional technology, we've been using it for decades. The viral vector vaccines, newer, but very high efficacy, and we do have years of experience. Nucleic acid vaccines, it's the newest technology, but actually, since we started using this back in December, we now have millions and millions of people receiving these vaccines with really robust safety data. So they may be new, but boy, they've had a lot of screen time. And then the protein-based vaccines, again, this is a proven technology, rather traditional, and it also has very little additives. It is just the protein. So this is actually an option in some cases for people that have had an anaphylactic reaction or issues with PEG, which I'm sure we'll get questions about. All right, next slide. Now, what if you get COVID before your vaccine? I spent a lot of time talking here about active traditional vaccines, but what about those monoclonals and what about those medicines that we need to be careful in our population? Next slide. So Antibodies, we talked about these. These are made by those B cells. This is one of those things that can protect us if we've been vaccinated and had enough time. But what if we didn't have enough time? Can we just get these? Can these be given to us? Next slide. And the answer is yes. And we've actually partnered with another group, Survivor Corps, long COVID community. And the data is pretty impressive. If you're not able to get that vaccine in time and you end up with COVID, or you get COVID before you have full protection from the vaccine, there's a whole list of people that are eligible to receive this therapy. 87% of the time, you get this therapy within 36, 48 hours, you're feeling all better. You're not going to the hospital. You're not getting admitted to the hospital. You're not dying. So really impressive data. You want to get this within 10 days after the symptom onset. So a narrow window, much larger window to jump in here with our vaccines. All right, next slide. And that winds things up for us. Now we're going to move into a lot of FAQs about vaccine versus infection. So let's just put up my last slide for a second. I'm here, for this talk now, but I'm going to be working with Keely and others going forward. So people have questions, or if people are looking for more information. Parasites Without Borders, we try to update on a regular basis, weekly, with what we think the latest important news is. And as mentioned, every week, this week in virology, we do a clinical update. And actually, a little proud of this. This is listened to on the International Space Station. That's what they do on Sundays. If you look up there in the sky and you're wondering, they are listening to This Week in Virology and getting their COVID-19 update. All right, thank you so much.
Well, thank you, Dr. Griffin, very much for that fascinating presentation. It's interesting that in the 27 years since I graduated from medical school, the number of advances we continue to make in vaccine development and understanding of immunology. So obviously, the topic of COVID-19 vaccine has been one of high priority in 2021. And this is certainly true for our population of G6PD deficient individuals. And so I think the overarching question that these people want to know is, should G6PD deficient individuals receive the COVID-19 vaccine? Is it safe for them to do so?
Yeah, so I think, and we're gonna repeat this repeatedly through the night. The short answer is yes, and the long answer is also yes. Right now, we're in a pandemic. The risk of getting COVID-19 is significant, and clearly, getting COVID-19 puts much more stress on the population, on the individual, than any of the vaccine technologies. And we'll go through individually each one, what concerns, what questions people have, and why, on the balance, it's always in favor of vaccination rather than risking exposure and disease.
And with that as a starting point, then people want to know, so if that is the case, which vaccine should they receive? What are the risks and benefits to each that you've described thus far?
Yeah, I mean, this is great. So I'll start off with my broad answer, but then we'll get a little bit into the weeds. And I'm going to start with a personal story. There was a nurse, one of the hospitals where I work, and she was vaccine hesitant, right? That's not anti-vaxxer. She had questions. She wasn't sure. She's thinking of getting pregnant. She's been thinking of getting pregnant for a while. And she wanted to know, and she had a lot of questions. We had several conversations. And then finally, she made the decision after waiting, right, a few months, right? She had access back in December. She said, Dr. Griffin, I've decided I'm going to go ahead. I've scheduled my vaccine appointment. She was very excited. She woke up the morning of her vaccine appointment with fever, not feeling well. She had gotten COVID right before she got her vaccine. So just sort of the issue of every day that you're waiting is another day that you can get COVID. So the short answer is, if you have an opportunity to get vaccinated, get vaccinated. Every vaccine is better than no vaccine. Then, as we'll get into, there might be little subtleties about why someone might prefer, one vaccine over the other.
Great. And certainly people oftentimes have more than one condition. They may be G6PD deficient, but they may also have some other comorbid conditions. So one question that has been raised by one person was, is it safe for people to receive the vaccine if they have COVID G6PD deficiency as well as an autoimmune disease? So for example, somebody who has Hashimoto's, which is a thyroid condition, or type 1 diabetes, and can they receive the COVID-19 vaccine?
Yeah. So the answer again is going to be yes. And why do I say that? We'll talk about each sort of class here in the US. It's easy. I'm going to only talk about the mRNA and the J&J. So the mRNA we've now administered to millions, tens of millions of individuals. We know the background percentage of G6PD in our population. So we are talking about hundreds of thousands of individuals with G6PD deficiency. With other things going on. So a subset of them are having type 1 diabetes, a subset has Hashimoto's, subsets have the whole array of different other medical problems. We are not seeing a significant safety signal. Actually, we're not seeing any safety signal. We're actually seeing that these appear to be the safest, most efficacious vaccines that we've yet had in front of us. The J&J, as mentioned, used in a large G6PD deficient population, about 20% prevalence in some of those areas. Years of safety data, not seeing a problem. So these are vaccines that are tried and true. People say, what about long-term? What about 10 years from now, Dr. Griffin? These vaccines haven't been around for 10 years. The nice thing that we know from all the decades of vaccinations is the long-term issues start in the first 6 weeks. We are well past those first 6 weeks for all these platforms. We're not seeing the problems.
That's certainly very encouraging and reassuring. And the next question kind of delves a little bit into some of the side effects that anybody, G6PD deficient or not, may experience with receiving the vaccine. And this question actually came up at a vaccine clinic that I was participating in just a few weeks ago, and a little bit of varied response there in terms of the advice. But the typical side effects so far tend to be things such as pain, redness, and swelling at the injection site, as well as some general or systemic effects, obviously, such as headache, muscle aches, fever. So the question here is it okay for people to take over-the-counter medications to relieve these symptoms, or will taking these medications suppress the development of an effective immune response to the vaccine and therefore the virus?
Yeah, so this is an excellent question. It's going to come up all the time. We currently do not recommend that people pre-medicate. In all honesty, I think we overplayed the reactogenicity of the side effects. Most people are going to actually do just fine. So you don't need everyone to take ibuprofen or Tylenol or antihistamines or anything ahead of time. Go ahead, get that vaccine, see how you do. If you start to have a fever, if you start to have a lot of muscle aches, if you find it difficult, it is okay to take Tylenol. It's okay to take these NSAIDs, the ibuprofen, the aspirin. Will it have an effect on your immune response? Nothing significant. In the studies where we saw the 100% keeping you out of the hospital, keeping you from dying, the 95% and even keeping you from getting any symptoms at all, in those studies, people were taking Tylenol. They were taking ibuprofen. The younger people, particularly the young men, were taking even more. I don't know, maybe they have a lower pain tolerance, but they were still getting tremendous efficacy. So is there some minimal difference that a scientist might tease on out? Perhaps. But is it going to keep you from getting the robust protection that you're looking for? No, there's no reason to suffer unduly.
Well, that's great. And with regard to the G6PD deficient population specifically, which medications for symptomatic relief should they take in these situations?
Well, fortunately, I'm going to say that the things that you would think about are going to be safe for this population. Tylenol is absolutely fine. Taking ibuprofen to leave, absolutely fine.
And also looking at signs or symptoms of side effects that may occur afterward. which signs or symptoms of an adverse reaction following a vaccine should prompt any person to seek medical attention?
Yeah, I mean, the nice thing is that the anaphylaxis, the trouble breathing, the severe reactions, they occur really within the first 7 minutes, and almost all of them within the first 15. So the really serious, worrisome ones, those are going to be happening right away. The palpitations, all the other, the acute allergic reactions, and we certainly see those, but actually at a lower rate than initially we thought we would see them. So you're going to see those right up front. The other side of the reactions we worry about is maybe it isn't just a vaccine reaction, right? Because you want to be able to distinguish this. Let's say it's day 4 and you're running a fever and you feel crummy. That's a little long for a vaccine reaction. Most of your vaccine reactions will be those initial allergic reactions within minutes to hours. Then a day later, you may feel that reactogenicity where you have a fever, muscle aches, feel crummy. That's not going to last for more than a day or so. If you're feeling sick on day 3 or 4, yeah, maybe something else. And unfortunately, we still have so much COVID that people actually show up for their vaccine appointment while they're incubating, while they're already infected with COVID-19.
And I think one final question that has been on the minds of several people is the fact that polyethylene glycol is a component of some of the vaccines. And the concern is that in certain formulations, PEG with other things is contraindicated for people with G6PD deficiency. But is it a contraindication in and of itself with regard to the vaccines in which they are found?
So this is an excellent question. So PEG 2000, polyethylene glycol 2000, is used. It's not actually preservative. It's part of that lipid envelope. It's part of that delivery system to get it into the cells. So it's really integral to the formulations of our mRNA vaccines. We, as people have probably seen, we sometimes see people have some allergic type reactions, right? People have those dermal fillers. We've probably seen pictures of the swollen lips, which subsides without any treatment. Apparently gets better quicker if you give someone an ACE inhibitor. I just saw a study on that today. If someone has G6PD and the issues with PEG 2000, this is different. This is not a formulation that we've seen issues with in the G6PD community. I know there are some, fake news, as I guess we've coined that term lately. Fake news out there. People are worried about that. There isn't any science behind that. But if you're worried about it, the nice thing now is we have another option. We have J&J with increasing supplies. Actually, I look at how many doses the federal government has purchased, about 200 million. So it's pretty much, I think, if someone has a hesitancy, I understand that. There's no science behind that. But if you feel more comfortable with one vaccine over another, I think we're moving this month into a point where you may be able to have a little personal choice.
It's great. Obviously making a lot of progress in a very short amount of time here. Thank you very much for responses to these questions. And I will turn this over to Keely for the next portion of the program.
Wow, that was an excellent discussion. I just wanted to keep going. And before that, I said, no, we got to make this really short. So thank you so much. It was just awesome, is all I could say. I wanted to also thank the audience. Some of you have submitted questions, and thank you very much for that. I want you to know that we have a surprise 4 speakers tonight. They are people who have volunteered to come out tonight from all around the world. The thing common about them is that all of them are G6PD deficient. They have G6PD deficiency, and they are all been vaccinated for COVID-19. We really felt that maybe you should hear their stories of why they got vaccinated and so on. So I'm going to first invite and introduce Chris from Malta. And if he seems a little tired, he has every right to be, because it's around 2 o'clock in the morning for him.
That's
if I'm correct. But welcome, Chris.
Thank you, Keely. Hi to all. I'm Chris from Malta, a tiny island in the Mediterranean. I'm 33 years old, and I've known that I have G6PD deficiency since age 10. Personally, the run-up towards COVID-19 vaccination rollout put me a bit in a dilemma. From one end, I am very much in favor of the global vaccination effort for multiple reasons. I was mainly, I know that it is the ultimate way that we can protect ourselves and our families and our loved ones. And secondly, because I've heard of people suffering from long-term effects months after being infected with COVID-19. On the other hand, I was concerned about whether the vaccine itself was safe for somebody like me who is G6PD deficient, who has G6PD deficiency. Apart from not being equipped with the scientific knowledge to make an informed decision, at some point during the past year, like many others, I observed a big spotlight put on certain antimalarial drugs as potential treatment for COVID-19 patients. With that in mind and knowing that I should avoid antimalarial drugs, I was questioning whether antimalarials and COVID vaccines share some common ingredient that I shouldn't or I couldn't consume. As part of my day job, I work at Malta's main general acute hospital. Therefore, I was going to be one of the first cohorts of people in the country to be vaccinated, which in our case, working in the healthcare sector means that we were going to be given the Pfizer vaccine. Nonetheless, 3 weeks after the vaccination rollout, and with over 95% of healthcare workers having been vaccinated, my mind had still some questions to overcome. In my case, the question was never really about the general safety of the vaccine. There was no cause of concern of the long-term effects that some people might feel concerned about, or the colorful conspiracy theories of microchips and whatnot. In fact, I was consistently encouraging my colleagues and friends to get vaccinated as soon as possible, especially those who, for some reason, had doubts following anti-vaccination campaigns. Though in my case, it was purely because of my personal condition. At some point, I shared my concern with a colleague of mine at the hospital, and she immediately offered me contact with one of the lead virologists in Malta to raise my concerns with him. Within minutes, I was on the phone with him, and he reassured me that this had already been raised with Pfizer, and that they confirmed that there was no cause of concern, because the ingredients that it has do not affect G6PD deficiency. So within 24 hours of that call, I had my first vaccination shot and the second one after 3 weeks. And I've had no major side effects other than a sore arm in the first shot and a slight headache of a few minutes after the second shot. My reasoning to take the vaccine, to get the vaccine, is that if my hospital is putting trust in my professional service, which frankly is not healthcare related, shouldn't I also be trusting the medical profession, which would certainly know much more than I do the best way forward from a medical perspective? Just to add some linguistic color to this, in Maltese, we have a saying, il-ħobb stieħ lil min jaf jieklu, which the literal meaning is, give the bread to the one who knows how to eat it. At the end of the day, everything boils down to trust. We trust the baker with the produce that he produces, the daily bread for us. We trust the mechanic whenever our car breaks down. We trust educators with our very own children. And why do I trust all of them? Well, I trust them because they certainly do a better job than I would, as they're backed with all the experience and knowledge that I certainly do not have. So, professionals in the healthcare sector should not be any different. If their scientific background and studies are recommending us to get vaccinated, then I'm confident that we should. So I do encourage everybody to get vaccinated. At the end of the day, it's one small prick towards immunity and one giant shot towards normality. Amlu courage. Have courage, stay safe. Thank you.
Thank you, Chris. May I ask you one question? What class of G6PD deficiency or variant do you have?
Unfortunately, I'm not fully aware of that. I've tried to get some tests recently because with all the information that has been going on around, I got more curious about how G6PD is affecting me. But unfortunately, I couldn't get any tests so far.
Okay, thank you.
Thank you so much, Chris. That was a very interesting story. And it really has so much meaning in what we're doing tonight. And I'm so glad that you did take the vaccine and that everything went well for you. That's awesome. Thank you. We are now going to introduce Brianne, and she's from USA. Brianne, are you ready?
Yes, I am.
Great.
Hi, everyone. So I have the heterozygous sub-Saharan variant of G6PD. I am 27 years old, and I will disclose that I am a part of the G6PD Foundation, G6PD Deficiency Foundation, as their dietitian. So I've been having a lot of conversations about G6PD deficiency and COVID vaccines. And of course, even as a healthcare provider, I was too apprehensive in the beginning when I heard about the vaccine and if that was okay for me to take. And I think the way that I came to my decision of getting the Johnson & Johnson vaccine was because I was obviously doing a lot of research on what COVID-19 looks like with G6PD for 14 to 20 days and how that amount of stress would affect my body. And similar to what Dr. Griffin was saying, you know, when we're weighing those pros and cons, having that vaccine and having maybe a fever, little aches, little chills for about 8 hours. And then after that, being perfectly fine to go about my life and do all the things that I do. Really, in hindsight, and also now, just strikes me as being very minuscule in the grand scheme of what could have potentially happened if I had gotten COVID. So, as a dietitian, there were some things that I did just to make sure that I felt great on the day for the vaccine. I got enough sleep. I ate fruits and vegetables and lots of antioxidants, and I drank lots of water and stayed hydrated. And I think, you know, it's really important to know that, you know, we are an immunocompromised population, and it's important that we take all of the safety precautions that we can. So that pretty much sums up the reasoning why I took it. And obviously, I'm here today telling my story perfectly fine. So I think it's important to just know that weighing the pros and cons of a trusted, safe vaccine versus a very unknown, very scary virus.
And Brianne, which vaccine did you receive?
The Johnson & Johnson.
I'm so happy that you decided also to take your vaccine, because I know how you were kind of going back and forth and a little concerned. So thank you so much for telling your story. We now have Giovanni from Italy. He too is up, but it's 2 o'clock in the morning. And he cannot speak English. He'll be speaking in Italian tonight. And we have provided a slide that will be in English so you can follow along in what he's saying. So I would love Giovanni to come join us.
Ok. Allora, buonasera a tutti. Mi chiamo Giovanni Agliuzzi, sono nato a Ferrandina, un paese in provincia di Matera, nel sud Italia, 50 anni fa. Sono affetto da deficit di glucosio 6-fosfato deidrogenasi, variante mediterranea, una variante di classe 2 ad alta prevalenza in Italia con deficit severo e rischio di episodi di anemia emolitica acuta. Sono un infermiere e lavoro presso un distretto sanitario dove ci occupiamo soprattutto di prelievi, assistenza domiciliare integrata e vaccinazioni. In questo periodo siamo molto impegnati su tutto il territorio provinciale con la campagna vaccinale anti-Covid. Lo scorso anno ho preso parte come infermiere alla task force della protezione civile a sostegno delle popolazioni del nord colpite dal coronavirus. Sono partito quindi dal sud Italia ed ho raggiunto la Valle d'Aosta per assistere gli ospiti di una microcomunità colpiti dal Covid-19 per sostituire i colleghi anch'essi contagiati. La solidarietà verso queste popolazioni flagellate dalla pandemia e il senso di responsabilità professionale mi hanno spinto a partire nonostante le preoccupazioni per la mia condizione di favico. Infatti nella prima fase dell'epidemia, anche dove ho prestato servizio, venivano somministrati farmaci a base di clorochina. Fortunatamente è andato tutto bene e sono rientrato a casa sano e salvo. Dal 27 dicembre 2020 anche in Italia è partita la campagna vaccinale anti-Covid. Noi sanitari siamo stati i primi ad essere sottoposti alla vaccinazione. Nel mio caso purtroppo è stato così. Dopo aver segnalato all'azienda sanitaria dove presto servizio la mia condizione di favico, sono stato messo in stand-by e in attesa dell'ok alla vaccinazione. Finalmente, dopo aver aspettato circa 2 mesi, il servizio di igiene e sanità pubblica mi ha risposto che potevo sottopormi alla vaccinazione. Mi hanno somministrato il vaccino Pfizer. Alla prima dose non ho avuto nulla di rilevante. Alla seconda somministrazione, nelle prime ore successive al vaccino, ho avvertito solo una lieve dolenzia al deltoide destro, mentre durante la notte sono manifestati i sintomi assai più importanti: brividi, febbre, dolori articolari diffusi e affaticamento. Mi sentivo uno straccio, ma questi sintomi erano anche il segnale che mi stessi immunizzando contro il virus. Ho assunto trachipirina con beneficio sia per abbassare la temperatura che per alleviare il dolore. Già nella giornata successiva stavo meglio, con una riduzione senza trattamento della temperatura e dolori articolari. Al terzo giorno la sintomatologia è del tutto regredita e sono tornato al lavoro. Recentemente la regione italiana nella quale vivo, la Basilicata, ha incluso il deficit glucosio 6-fosfato deidrogenasi come categoria ultrafragile, con priorità nella vaccinazione anti-Covid-19. Riguardo alla mia esperienza di fabico con la vaccinazione anti-Covid, posso dire che ho manifestato gli stessi sintomi e gli stessi effetti collaterali, comunque lievi, previsti dal vaccino per il resto della popolazione. A mio avviso, noi fabici non corriamo alcun rischio con il vaccino anti-Covid e forse rischiamo di più se ci infettiamo. Thank you.
Thank you, Giovanni. Are you sleepy? It's all wonderful that you joined us.
Tomorrow work.
Oh, very interesting story. And we really appreciate it that you were able to get it translated.
Thank you for foundation, and thank you, Dr. Carmela Grieco, for support and translation.
Yes.
It was a
Carmela,
pleasure.
thank you so much.
And just in case, if someone has any doubts or questions, I can help in case.
Thank you. Okay, so we have one more guest speaker, and it's not, I'm so excited that I got to know Mike prior to him getting vaccinated and how he had contacted the foundation. And I'm so happy he's here tonight to talk about it. This is Mike from USA. Welcome.
Hello, everyone. How are you? So I'm Michael. I don't know which variant I have. I just know that G6PD runs in my family. A lot of my family members have it. I'm actually a frontline worker. That's why I chose to get vaccinated. But I didn't know how I was affected. I didn't know that G6PD populated people were at high risk. So my job, they would do webinars just like this one twice a week to inform people, also to promote people for getting the vaccine, because a lot of people are on the fence about it. So I had questions like, how am I affected? Can I get it since I have G6PD? Some of the coworkers actually had it too, and they introduced me to the G6PD Foundation. That's how I met Kylie, and she told me some things. She answered some of my questions that I had. She also pointed me in directions to talk with doctors. So I talked with doctors. They did recommend that I do get the vaccine because they said if I catch COVID, I could be at more risk because there's a lot of treatments that I can't take. So I decided to get the Pfizer vaccine. After my first shot, I was okay. I took an extra day off of work when I got my second shot because I did hear the rumors of how some people would feel, but I felt fine. I had no reactions. I do have a cousin who is also a frontline worker who got the Moderna shot, and he did have some reactions. He was very tired, very winded afterwards. But as for me, I was A-okay. So I do recommend the Pfizer shot for some people who have G6PD that are on the fence.
Thank you so much, Mike.
You're welcome.
Okay, so I think everybody should get ready for the questions for the audience. I really want to thank the 4 speakers for coming out and really telling us your private story about this. This is something that is really special, and I think it was really needed for people to hear the different stories and why you got vaccinated and so on. So truly, thank you. And so I hope everybody is now up on stage, and we're going to start now with the audience question answer. We'll have Dr. J Vick. He will ask many questions from the audience that the time will allow.
All right, thank you, Keely. And I'd like to echo that thanks to the 4 speakers as well. It's much more meaningful, I think, to hear it from people who are living that experience. First question that has come to us for Dr. Griffin is there any information about the effects of the second shot for those who have already received the first shot that might be of relevance to the G6PD deficient population?
Yeah, thank you for that question. You know, what we've seen across the board is whatever reaction you have the first time, you may have a more significant reaction the second time. I was seeing if Brianne was raising her hand to say yes to that or not, but she had the J&J, so she only got 1 shot. No, we're not seeing anything special or concerning or worrisome or anything like that in the G6PD population.
Okay. And then kind of a general question that I know a lot of people wonder about is, can a person still contract COVID-19 after being vaccinated? And if so, can that strain then be transmitted to others?
Yeah, so, you know, the only thing in life that is 100% is death. Al Capone taught us that taxes was not 100%. The vaccines are tremendous, right? And, you know, in a young, healthy person, it looks like they're close to 100% at preventing you from ending up in the hospital, preventing you from dying. But we certainly see people get infected after they've got full protection. The studies were saying about 95%, and we're actually seeing about that. They tend to be milder. You know, has anyone who's been vaccinated ended up getting COVID-19 and ending up in the hospital? Yes, they have. I've taken care of a couple individuals. You know, these were individuals that you would expect to meet. They're in their 90s. They're living in a nursing facility. They have multiple problems. They don't have that robust immune system to respond to the vaccine. So it's not 100%. And I think that also is part of why are we still wearing masks? Why are we still doing all these other things? Because we're still in a pandemic. We still have thousands and thousands of people dying every day around the world. And what is it, about 500,000 people get infected per day? So yeah, the vaccines are great, but we're still basically living in a pandemic viral war zone.
Yes, indeed. There's been some discussion about the use of graded doses of the vaccine, especially in people who have a history of allergic reactions to, various, drugs or perhaps vaccines. Should a class 1 G6PD deficient patient consider graded doses of the vaccine, as has been done for those who do have severe reactions to vaccine? Is that an issue?
No, this is a great question. It's actually actively being studied. We'll have more information going forward. What would I say in your class 1, most severe? I talk about the shared decision making, and maybe actually steering them towards the J&J versus the graded, because we're not really sure how that's going to, give you the protection, right? It's going to be really hard to study the protection response using these sort of graded approaches. The other, right, if other than the J&J, is potentially something like a Novavax. So I'm not sure the science is there to support the graded approach, but if people have concerns, maybe thinking about some of these other options out there. What I'll say is that I because some of our people listening maybe are outside the US, so just talking about some of the other vaccines out there. Again, the same thing, whether you're using a Sinopharm from China, whether you're using the AstraZeneca, which has been, over 30 million people in the UK given this as well. Again, we're not seeing issues in the G6PD population with these vaccines, even in the class 1. So I think that at this point, I would recommend sticking with the studied approaches.
Which makes a great deal of sense. There's been some discussion about the entity known as long COVID, and perhaps it's too early to tell, but can one get long COVID after one has been fully vaccinated?
So we are actively investigating that, actually. People have been very generous with funding research during these times. They should have always been, and we wouldn't be in these times, I think. But we are hoping that the vaccines prevent that. And actually, I think we're seeing that. It'll be exciting when we can actually get that stuff out published. But we're not seeing many cases of long COVID in people who are previously vaccinated.
Okay. Very helpful information. We're running close to our time here. I will ask one, maybe two more questions. The first one is blood clot issue with the AstraZeneca vaccine of any significance for the G6PD deficient patients?
So, this is evolved actually pretty quickly from, boy, we're seeing a few of these, to actually we're seeing about these in about 1 in 600,000. And actually it's maybe even a little bit of higher if you start looking at younger individuals versus older individuals. Now 7 deaths in the UK. There is growing evidence that there is a connection between the AstraZeneca population and these clotting disorders in younger individuals. So a lot of countries have preemptively actually moved the AstraZeneca vaccines to older individuals and other vaccines to younger individuals. We're not seeing any specific issue with the blood clotting disorder specific to the G6PD population. And I have to say that would be something very quick and easy for us to discover. So far, we're not seeing a special concern here for the G6PD population.
Okay, again, something that's very reassuring. And finally, the last question, you mentioned something about younger individuals, and certainly we have been seeing adults of many ages being vaccinated, the age range coming down. But when the vaccine is available for children, will it be safe for G6PD deficient children? And how vulnerable are G6PD deficient children to potentially hemolytic anemia if they get COVID-19 prior to vaccine?
Yeah, and I think I can continue with the same sort of reassuring safety message here. We just saw the data from Pfizer down to the 12-year-olds, so 12, 13, 14, 15. And actually, this was impressive. They weren't just waiting to see if someone got sick. They were swabbing these kids every week. And how efficacious was the Pfizer vaccine? 100%. Not a single vaccinated kid tested positive, despite that we're living in a pandemic with this high exposure. 18 kids in the placebo arm ended up becoming PCR positive, getting COVID. And what about safety? It was great. There were no safety issues in these kids. So we're looking at, thousands of these younger individuals. And I mentioned the experience with J&J. This was given to kids as young as 4 months of age in a population with a 20% prevalence of G6PD deficiency. There were no issues in the kids. So we have good safety data for years of using that platform in kids with G6PD deficiency.
Well, that's great. And again, another piece of reassuring information. I see that this brings us to the top of the hour. So Dr. Griffin, I want to thank you as a colleague for your wonderful presentation and for fielding these questions this evening. And I'm going to turn the program back over to Keely Harris.
I am just so thankful for tonight. And I hope we've helped a lot of people make a decision whether or not to get vaccinated for COVID-19. And if you are G6PD deficient. I think it also, what we spoke about tonight is also very good for anybody to read or watch. We are recording this, and we are going to definitely have an email sent to everybody who registered, and it will have a link in there, and it will lead you to the recorded version of tonight's webinar. And you should be getting that in a couple of days. If there's a question tonight that was not answered, in that email, we will give you the information of where you can send your question. And we hope maybe down the road we can send you an answer, or we'll have it on the website with these answers for questions that weren't mentioned tonight or asked or answered. I also want you to know that it's so important. If you or someone you know has had an adverse reaction to any vaccine, there is a place that you should report it to. And you will report it to VAERS. It is VAERS.hhs.gov. It's so important that people know that if there is a problem, this is how they're going to find out. So I'm sure everybody stay well, stay healthy, and please, I hope your decision to get vaccinated is a positive one. Have a good night, everybody.
Good night, everybody.
Good night.